Okay, how many people were on call? Raise your hand. There's got to be a few of you. Okay, so my goal is to try and keep you conscious. If I don't succeed, there's no eraser for me to throw at you, but we'll try anyway. I find ways to do this. Laser pointers work pretty well. I'm Tina Palmieri, and I am the Chief of Burns at UC Davis and the Associate Director of Burns at Shriners. And this was a tremendous honor. There are a few icons in burns, and the icons change over the years. Dr. Hansbrough was one of my icons. As I was in training, he was the person that I looked up to and said, he knows burns, he knows the future of burns. And I want to go into burns partly because of him. So it's my honor to be able to give his lecture. And we didn't plan this. All those attributes that Dr. Potenza discussed, I'm going to touch on pretty much everyone except for maybe one of those today in my talk. Now you're probably asking yourself, oh my God, we're going to talk about saving someone with no skin left. How horrible. Burns are really hard. But there's one thing about burns that was alluded to very early today. Burns transcends a single disease state. The principles of burn care can be applied to trauma. They can be applied to cancer. They can be applied to anybody with an acute illness. So although I'll be talking specifically about burns, I'd be very surprised if you don't see a few things else. So today, what am I going to do? I'm going to tell you what burn mortality is now, what it's been, where we've come from, and where we're going. And talk about some of the advances we've made in the major areas, in inhalation injury, resuscitation, wound management, and anabolic agents. Yes, this is the state with Arnold Schwarzenegger, right? So we have to talk about anabolic agents. And finally, I'm going to get to the heart of what was probably your first thought when you read my title. Should we be saving people with a 98% burn? And we'll have an interesting discussion about that at the conclusion. So this is the past, and this is how slides were done in the past. These were done with rulers and people filling in things, and this was before the computer age that really kicked in. This is the past in burns. This is 15 to 44 years of age. So in 1950, a 15 to 44-year-old person died, half of the people died with about a 45% burn. And if you were greater than 65, only a 10% burn would kill you. So, remembering the rule of nines, your arm, including your hand, is 9% of you. If all you burned was your arm and you were 65, half of these people died. That's pretty significant. Over the years, you can see that that LD50, which is the point at which half the people die from a burn injury, has gone up. If you're 15 to 44 in the 1980s to 1990s, a 70% burn had a 50% survival. Note, however, if you're old, which, 65 is getting kind of close, so I'm thinking of just raising that, trying to start a trend. Let's try and raise that up to 85. But that's where we were in the 90s. Where are we today? And this is data from the National Burn Repository. And the National Burn Repository is contributed to by a bunch of burn centers throughout the United States. And this is the LD50, currently between 60 and 70%. That's for all age groups. So half the people who sustain a burn between 60 and 70% will survive. When you're saying to yourself, well, that 80-year-old, I kind of doubt that they're going to survive that 60 or 65% burn. So let's look and see. Let's drill it down. Yes, I expect you to memorize every number on this slide and recite it back to me before we're done. I highlight in yellow the LD50. If you're over 80, no, we haven't made a heck of a lot of progress, have we? It's 20% burn. But if you're over 80, a 20% burn has a 50% mortality. If you're between 5 and 15, those teenagers, you can't stop them. And you can't talk to them either, but they survive just about anything. And so their LD50 in anyone who's in that age group is well above 90%. So we can save more than half of those children. And so this is where the recommendation to resuscitate everybody in that age group comes from. And you can see as you get at the extremes of age, the very young and the very old, we fall down. And we're not quite as good. And we'll talk about that a little bit later. So there is an age difference. So how do you get someone with a 98% burn to survive today? And if you want to map it out on yourself, your palm, including the fingers, is 1% of you. Okay? So 2 palms on your thigh. That's all you got that's not burned, just to make it real. So how do we do this? Things have to go perfectly. And we'll come back to the answer to that question. Now, there are some things in life that we can't change. Okay? You can't change where you were born. You can't, well, it used to be you couldn't change your gender, but I guess you can do that now. But you can't change the year you were born. And these are some of the things that we see in patients that we cannot change when they come. We can't change their age. We can't change the fact that they have diabetes or other diseases. We can't really change the burn size significantly. We can't influence the fact that they inhaled smoke. The paramedics are out there, they're putting the lines in. We can't influence that once they're at our door. We can influence it before. And the interval from transport to the burn center. We can do as much as we can to diminish that. However, we can't ultimately change how long it takes. And all of these things have been associated with adverse outcomes. The longer it takes you to get to a burn center, the older you are, the bigger your burn, all influence your final outcome. So these are the things that we cannot change. So until we find the fountain of youth, we're going to have to go something else. So what we're going to talk about today are those 4 areas I talked about in the beginning: the inhalation injury, resuscitation, wound management, and anabolic agents. So how have we been doing in inhalation injury? This is isolated inhalation injury. That means no cutaneous burn. So what is the mortality, or what is supposed to be the mortality for a coronary artery bypass grafting? Open heart surgery, less than 5%. Okay, do you see less than 5% on any of these slides? Okay, if you have inhalation injury, your chance of dying is greater than if you have open heart surgery. Okay, that also helps to put things. We have come a long way. In 1986, there was a 56% mortality with inhalation injury alone. It has dropped to 12% in 2006, and then the latest figures are even a little bit lower than this. And so it raises the question, what are we doing and what can we do to make this better? Basic principles of burn surgery, maintain, and trauma surgery as well. Get the airway straightened out, ABCs, right? These are the things that have been happening in the last 20 to 30 years that have improved outcomes with inhalation injury. You give them oxygen, you assess them for early intubation, you intubate them when they need to, and identify inhalation injury. And these are all classic findings for inhalation injury for those people who haven't done burns. If someone's trapped in a building, if their mouth is full of soot, if you do a bronchoscopy and you see airway injury, and measurement of carboxyhemoglobin levels. So by the way, what is a carboxyhemoglobin level at which you have to worry? Just as a trivia point, greater than 10, okay? And so those are things that you have to watch out for. But then I ask you to ask yourself, what is inhalation injury? Everyone always thinks, well, it's the smoke. But is it? I would posit to you there's 3 different types of inhalation injury, and what we have done in the past 10 years is actually talk about the 3 different types of inhalation injury and how they need to be addressed differently. There's obviously hypoxia. So if this room were to catch on fire, the FiO2 of this room would go down to 10%. The majority of people who would die in this room would die from asphyxia. And that is one of the leading causes of death after burn. Now, if you manage to survive that, you have to worry about carbon monoxide toxicity, which would be coming from the things that are burning in the room, and cyanide. Hydroxycobalamin has become very popular in the treatment of cyanide toxicity. Then the second thing, and this is what ER docs get really pumped up about, is that airway obstruction. So the patient comes in and they're stridorous when they come to the ER, and rightfully so. You should get excited because they are stridorous, their airway's edematous, and they need intubation right now. Believe it or not, a lot of those patients that I showed you in the 1950s died because nobody recognized they were losing their airway. So that is another type of inhalation injury that needs to be dealt with in a slightly different way, okay? It needs to be dealt with endotracheal intubation. And finally, it's the actual smoke. And the smoke inhalation injury portion needs mechanical ventilation. And I would posit in the last 20 years, this is where we've made the successes. And those successes have not necessarily come from specialized burn thing. This is where the success for lung damage after inhalation injury has come in the last 20 years. It's the ARDSNet, and for every student and resident in this room, this should be mandatory reading. This ARDSNet clinical randomized prospective trial of low airway ventilation pressures versus higher airway ventilation pressures. This is a classic article, and you should read this because this is a very well done study, has changed how we ventilate patients, mechanically ventilate patients. So I highly recommend it. And what they did was they got a bunch of clinicians to actually agree on a protocol to run a ventilator, and they actually carried out what they said they would. And they found that patients who had the low tidal volume ventilation weaned better and had less barotrauma. And it has decreased the incidence of pneumothorax and iatrogenic lung injury tremendously. And I think this has really worked to help people come off the ventilator. It also decreased mortality. So now we are ventilating people actually much differently than when I started in critical care. We're using lower tidal volume ventilation. We're doing a lung gentle ventilation strategy. And that, I think, has been one of the leading causes for the decrease in mortality from inhalation injury after burn injury. And this is, in case you're wondering, these are the ventilator settings that were used and that are recommended nationally for ARDS and severe lung injury. So this is not just a burn thing. This is any patient with severe lung injury, any trauma patient, any patient in the intensive care unit. You want to keep the pressures low and try to keep them ventilated. So of course, we in burns had to do it one better, right? If low tidal volume, low pressure ventilation was good, this is a different ventilator. This is called a volumetric diffusive ventilator. Has anyone heard of it before? Other than Dr. Potenza, I'm sure he has. Okay. The VDR, as we call it, was invented by Forrest Bird, who invented all ventilators. His first wife, he's had 5. His first wife had alpha-2 antitrypsin deficiency. And he invented this ventilator to treat her. Now, alpha-2 antitrypsin deficiency means that she cannot get rid of her secretions, her pulmonary secretions. She needed something to help her get rid of secretions. And he would use this ventilator, like an IPV. This is one of the origins of IPV as well, to clear her secretions. He actually prolonged her life by between 5 and 10 years doing this. So this is the origin of it. This is actually a cross between an oscillating ventilator and a pressure control ventilator. So you have all the advantages of both. And for people who've used an oscillating ventilator, you know the problem is CO2 retention. This, because you cross it with a pressure control ventilator, you can actually get rid of CO2. It's a very fun ventilator. You can use high frequency breaths with an underlying rate, which is actually that of a normal ventilator. And breaths are stacked to get a normal rate and pressure. And the best way to describe it is it looks like a normal mechanical ventilation tracing having a seizure. Okay, so these are all the little breaths, and the little breaths get stacked up to maintain a larger lung inspiration and drops down. And this allows you great flexibility in controlling CO2 as well as oxygenating. And there are very few people you cannot oxygenate on this. Now, Dr. Bird is brilliant, and the rest of us are humans. And the first generation of this ventilator, way back when I was in training, just had knobs that said A, B, C, D, and E. Now you had to know what A stood for because it wasn't written down on the ventilator. Now it's mechanical, but you can see this big red thing here? That is what is attached to the endotracheal tube. So it's very heavy, and it has to be supported, so nursing staff have to see it. Have to be very careful because it can actually extubate the patient. And you're asking yourself, why would anybody use this thing? Okay, it sounds okay, but what really happens? These are some of the studies that have been done to look at the results. In this study, the patients were looked at using the VDR compared to normal ventilation, and as you can see here, there was a great improvement in P to F ratio. So in other words, patients were oxygenating much better. And you ask yourself, okay, were they using the same pressure? Well, guess what? They used lower peak pressures to achieve the same result. And consistently, whenever I switch from a traditional ventilator to a VDR, I actually decrease the peak airway pressures by about 1/3 because a third of the amount of pressure will actually achieve the same thing. And remember from the ARDSNet study, less pressure, better outcome. Same thing here. This is in children. You can see that the incidence of barotrauma went from almost 30% to 7%. Lower airway pressures, less barotrauma, fewer chest tubes, so sorry about that for those of you who need to get your chest tubes inserted, okay? But better for the patients, okay? Less barotrauma, patients do better. And finally, where the rubber hits the road, mortality is lower, pneumonia is lower, because this ventilator actually serves to get rid of secretions. So this has been one of the advances in burn care that I think have also helped, but you can see why it helped. It's because of that decrease in pressure and decrease in barotrauma. So why isn't everybody using the VDR? Like I said, Forrest Bird was a genius. It's because he changed all the variables, so tidal volume, those kinds of things. Everything has a different terminology. It requires a special ventilator, and it requires a respiratory therapist, nursing staff, and physicians all to be able to think differently. So if it does everything just the opposite of what a traditional ventilator does. So you increase the rate of those small breaths, and you actually retain CO2 instead of not retaining it. And so it's one of those things that takes a while to get used to. The patient tolerance. When I first started using this ventilator, one of my policies, and yes, I am crazy enough to do this, is to try every mode of ventilation myself. Yeah, I tried sometime. Now, I didn't let anybody put the endotracheal tube in, okay? I just restricted it to the nose clip. My chest hurt for a week after this. It's very unnatural. But I had a cold at the time, and by the time I was done with it, I was quite cleared up, thank you. The phasotron is heavy, and weaning is challenging because it's not the normal way to breathe. We don't breathe 1,200 times a minute. That's just not what we do. So this is where we're going with inhalation injury. Actually, right now, our multi-center trials group has funding from the Department of Defense. We're actually defining inhalation injury and setting up a scoring system for inhalation injury so that we can really quantitate how bad it is. You would think after all these years we would have that documented, but it's not quite as simple as you see. Inhaled nebulized therapies. My favorite is beta-2 agonists. We do continuous albuterol very frequently. We've got sheep studies to back it up. It works very well. And then different types of mechanical ventilation. The pressure release ventilation made a big surge a while ago, and it's kind of faded out. It never really caught on. I haven't really caught on with that very much. I've used ECMO a lot less now that I have all these other ventilator options. Okay, you still with me? This is the fun one. Everyone likes resuscitation because you feel like you did something, right? People die if you don't resuscitate them. In 1930, as I showed you before, renal failure was the leading cause of death. It wasn't until Dr. Moore sampled blister fluid from burned patients in the Coconut Grove fire that it was realized that we should actually give burned patients fluid. Before then, they thought, they're swollen. We need to give them less fluid. And this was a turning point in burn care. Multiple formulas have been started since that point in time, and the incidence of hypovolemia has decreased. However, we're giving a lot of fluid. So guess what happened? A little bit's good. You know, a little bit of chocolate cake is okay. So you have to have that second piece, and then you have the third piece, and what happens? You're sick, right? We're doing the same thing with fluid. We sometimes have this issue of what's called fluid creep. And Dr. Pruitt, who is probably the master of naming things, developed this term to describe the fact that over time we are giving more and more and more fluid. And our patients start to look like the Michelin Man because they get so edematous. Now, at first it was good because people would have adequate urine output, but as you give too much fluid, you start getting complications like compartment syndrome, where your arm or your leg swells up so much that no blood flow gets in. Intraocular hypertension is now being documented, and several blindness episodes have been associated with that. Pulmonary edema is what we see a lot of. Massive edema and abdominal compartment syndrome is one of those things that everybody sees because of increased fluid. So the question comes, why can't we get this right? Well, the formula could be wrong. People can't or don't follow the formula, and we all know, if any of you who have 2-year-old children know that They won't follow anything you say, right? And doctors are big 2-year-olds, right? So we have problems following what anybody tells us to do. Patients don't follow the formula. The patients don't read the book. Patients will adjust to their injury as they are programmed to do so. We can't change how they do that. And finally, you have to ask ourselves, is the problem the formula or the creep who is supposedly following the formula? Now, that doesn't implicate just doctors or nurses. It implicates, I think it's a combination of everybody. So everybody loves a formula. Now, whenever you see someone put up like 10 formulas, there's at least another 10 here that I haven't put up. It tells you one thing. None of them is right. Because if there was one right formula, how many formulas would I put up? One. But these are the formulas that have all been started throughout the years. Parkland is probably the most popular within the United States. And the important thing with any resuscitation is the patient response to resuscitation. So I take these with a grain of salt. So you get your choice. You can pick Dr. Warden's way. You can pick the Cotswolds way, so you can do how they do in England. Or the Monarch, Dr. Pruitt's way. The Heart of England way, which is anybody's way, and the Gloucester way. So everybody has their own way of resuscitating, and you have to pick your own. This is from Dr. Baxter's, again, this is the age of rulers, slide rules, etc., from his original paper on burn resuscitation, which was initially published an 11-patient series, and 7 of these 11 patients actually adequately resuscitated. So it's very interesting. This is to set the tone for burn resuscitation. And you can see this is the curve of how much fluid these patients needed based on the Parkland formula. And what you can see is that at the very beginning, the formula underestimates how much you need. And at the end, it overestimates. So going blindly by a formula probably isn't the right thing to do. So if we're the creeps not following the formula, that's okay, because the formula isn't totally right. So the important take-home message is that you adjust your resuscitation based on your patient's response. Not necessarily, so use the formula as a start and then adjust based on the patient. Don't make the patient adjust to you, because they won't. You have to adjust to the patient and what the patient's doing. Now, any formula for burns relies on 4 things: patient weight, the burn size, the burn depth, and the urine output. Those are the 4 parameters. Now, they sound really easy, don't they? Sure, no problem, weight. Okay, who here has weighed somebody in the emergency room? Anyone know where the scale is in your emergency room? Okay, I'll tell you, I have no clue. I don't think they have one, but I'm sure they would be offended. They probably have one in a corner somewhere. But I've never seen a trauma patient weighed. I've never seen a burn patient weighed until they get up to the unit. So even something as simple as measuring somebody's weight doesn't happen. I usually use the driver's license and add 20 pounds. Okay, burn size, you can estimate. Okay, the rule of 9s. Everything is a multiple of 9. Your arm is 9% of you. Your legs each are 18. Your anterior trunk is 18, and your head is 9. Babies have bigger heads, so a baby's head is 18% of them. Burn depth, first, second, and third degree, and urine output. That is how you adjust your fluids, is by monitoring that, at least at this juncture. That's something we'll be talking about. So what changes fluid requirements? I told you these formulas are not right. You have to adjust based on the patient response. All of these things impact how well the patient's going to respond to fluid. You never, ever, ever see anybody with alcohol or drugs, right? Yeah. About 30% of my patients come in with either alcohol or methamphetamine or marijuana or, you know, all the sundry other things that you see in your tox screens. It increases your fluid resuscitation requirement. Delays in resuscitation. I had one patient show up 12 hours later, required 10 times the normal fluid volume to become resuscitated because it turns into a cascade effect. Other illnesses or injuries. Someone who's in a car wreck, who has a ruptured spleen, has to have their spleen out right away, is going to have an increased fluid requirement. Electrical burns, I call this the iceberg effect. This is the Titanic of burns, because you see the very small entrance, and the injury can be much more massive than that. And this is where I raise a very controversial topic: continuous opioid use. Do you guys use opioid drips? Yeah, a lot of people do. I stopped doing that. It took me about 3 years to stop doing it. And the reason why, obviously we know, well, first of all, it decreases pain, you decrease cortisol levels, you decrease tachycardia, and it makes everybody feel good, the patient and you, right? The downside of continuous narcotics is that they vasodilate. And we've actually gone back and looked at our resuscitation. And when we used continuous narcotic infusions, our incidence of abdominal compartment syndrome, as well as our volume of fluid, was sky high compared to when we used intermittent for the same size burn. Much more fluid was given. We were giving a lot of fluid just to compensate for it. Bowel complications, it's rare, but you know, people having constipation is a real issue as time goes by. And there is data coming out that T-cell responses and B-cell responses are affected by opioid use. And I'm watching this data and I want to see where it goes, but to me it's very fascinating. So I've actually gone to some background opioid orally with intermittent intravenous, making sure the patient stays comfortable. But just by stopping the continuous intravenous, it has helped us a lot, especially with abdominal compartment syndrome. Our incidence of abdominal compartment syndrome release went down tenfold. So I found that to be helpful. I wasn't very popular for about 2 years. I just wore a flak vest as I walked through the unit. But I would say our pain control, we're very careful about that, is still good. And surprisingly enough, it took a while, but I won over everybody because I made sure patients had their pain control, but in a slightly different way. So, or is the problem simpler? People don't like to decrease fluid rates because they see that urine output, and if a little is good, more is better. Not necessarily true. People forget to measure urine output. I mean, everybody's human. And some people forget to monitor the urine output, so they measure it a 2-hour urine output instead of 1 hour, and suddenly they realize that, wow, it was 200 over 2 hours. Oh, I should have turned it down last hour, but I didn't measure it, so I got to catch up now. Urine output may not be the best marker, and I suspect that's probably the case. It may not be a good marker of resuscitation. Lactate-based deficits, we've been looking at strong ion differences. Invasive monitoring, there's actually a study that puts swans in burn patients, Swan-Ganz catheters, to use that to guide resuscitation. Believe it or not, you ended up giving between 1 and 2 liters more fluid to the patients, and they had a higher incidence of abdominal compartment syndrome. So the swan's probably not the answer at this stage. So what is the future? Right now, there's someone who has actually figured out a way to have the urine collected in a bag, registered in a computer, and tell the nurse how to change the IV every hour. This is being done in the military. So it's a computerized algorithm for changing IV fluid based on the urine that's collected by a computer. We need that better marker for resuscitation. Colloids, for those of you who've read the SAFE study, unfortunately Burns was left out of this. It would have been nice if they put it in, but I think we would have messed them up. And the holy grail is still that perfect resuscitation formula. So we'll probably still be looking for that in 20 years from now. Next, okay, wounds and wound excision. This is a burn talk, so I got to talk a little about wounds. I've been very good about not showing you any gross pictures, so we'll have to see how far we can go here. So burn wound excision, we got a bad rep, and that was because people used to wait and wait and wait and wait. And about 10 weeks later, after things were pretty ripe and the burn unit was quite an interesting smelling place at that point in time, then people would do something. The problem is that people got infected, they had long hospital stays, they got contractures, and were dying. And then came early excision. Dr. Jankovic is actually a female plastic surgeon who actually went through quite a bit of resistance and developed the concept for early burn excision. And this is the small knife. It's only about this long. It's called a WEC or a Goulian. And you tangentially, so at an angle, you excise the tissue, you remove it, and then accompany it by immediate wound closure. Now to do that, you're obviously going to bleed, so some techniques had to be developed. Early excision, and I define that as within the first week of burn injury. It improves survival. It definitely shortens your hospital length of stay. It decreases your bacterial colonization and the number of septic episodes, and it attenuates the systemic inflammatory response. And for burns, this has really been a big breakthrough. And burn surgeons who do necrotizing fasciitis are also very early grafters and excisors because of these exact reasons, which is controversial actually in the neck fasc world. There's a prospective randomized trial of 85 adults. This will never be repeated because I don't think ethically anyone will be able to do so. With greater than 30% burn, improved mortality, 45% versus 9%. Huge difference in mortality. And in children with 40% burn, the delayed excision group got more infections and sepsis and hospital length of stay. But remember, 5 to 15-year-olds are tough, so they're going to survive this stuff. Your 80-year-old grandma is not going to be tough and survive that bout of sepsis. This is a child who came to us who had had their burns kind of picked at for about 6 weeks. And this is what happened. And you see what happened. This is the subluxation of the child's joints. I call it the stop in the name of love position because you're stuck like this. Okay, this is from lack of wound closure. If you don't close the wound, what kid is going to want to move that hand when that wound's open? You've had it cut. You don't move your finger, right? His whole hand's open. How much do you think he moved it? Almost none. So this is how he gets frozen. And what we actually had to do because of the delay was actually take him to the operating room and bring his hands forward and literally reopen the wound and pin his hands. So his hands will never be totally functional, but I call it the can of beer phenomenon. My goal is that every child in the future of his life will be able to drink whatever he wants and to write, okay? So the good news is he can write so he can attend school. In the long term, he can always have his beer if he wants it. This is what happens early excision. Deep burn, and that's the grafted hand. Fully functional, fully able to do it. So early excision, not only life-saving, but function. And remember, what's the purpose of surviving a burn if you can't do what you want to do? Okay, and we'll come back to that in a little bit. What are the risks? It's difficult to determine that initial burn extent in the first couple days. So it's a learned being able to assess a wound early. And sometimes you're right, sometimes you're wrong. Using cadaver skin for places when you don't have enough. Blood loss. The blood bank calls me a vampire. In burn surgery, we lose 2% of a blood volume per percent burn excised. So if you do an arm, that's even with tourniquets, that's 9% of you lose almost 20% of your blood volume. That's a lot of blood. A week ago, we did a 95% burn. We did every face. He lost about 5 liters of blood. So he lost almost an entire blood volume. You need the technology, you need the team ready to do that resuscitation. Excising during a resuscitation, I personally wait until the initial resuscitation is done because it's not fair to your anesthesiologist to expect them to run fluids at 2 liters an hour and give blood and keep up with you. You just don't have enough lines to do it. You need an operating room, and then the old people. When do you do them? Because it's clear that what we're doing for old people is we can do better without. Here's the future. This is one of them. And this is where Dr. Hansbrough came in. He was one of the early advocates of cultured skin. And we've actually participated in a project with Dr. Steve Boyce in Cincinnati. And we biopsy the patient's skin, we grow the keratinocytes, graft it onto a matrix, and cover with minimal donor. So the donor is about this big. Okay, now the problem, we'll come to that in a minute. So this is an illustration, a scientific illustration of how he gets all these different cell types, puts them in a collagen substrate, and then grows it. Now the nice thing about this is that he puts it in a dermis. Otherwise, if you just grow cultured skin cells, they are the texture of single layer wet toilet paper. Okay, not Charmin, none of this double weave stuff. Okay, it's the single layer, and it's that strong, which tells you it has no turgor. This is the turgor of almost normal skin. And this is how he actually sends everything to us. We put it on the patient, and this is what it looks like. A bunch of little pieces of gauze, and this is the patient. Now, you notice something's missing here. This is an African-American child. What's missing? Pigment, right? The FDA won't let you put pigment in because they're afraid of getting melanoma. So what little pigment he has is what little pigment was left in that skin. But this little boy had a 95% burn. He burned everything but his cornrows and where his elastics were. And this covered his entire chest. And he actually walked out of the hospital and cried massively the next time he saw me in clinic, which is actually a sign of mental health. Okay, this is progress, but there are some limitations. It takes 3 to 4 weeks to grow skin. So if I can get you covered with your own skin in less than 3 to 4 weeks, that's what I do. The pigmentation, no sweat glands. Just imagine you're running a marathon and you can't sweat. Burn patients overheat a lot. That's a big problem, actually. It's fragile, it's expensive. Actually, the skin gets bought, a courier usually comes if you get it from Genzyme, and they charge you $5,000 for the seat that the skin takes up, and whatever the first class ticket for the person bringing the skin. So it gets really expensive. I've spent on one patient $500,000 in cultured skin. And it is a gamble because it doesn't all take. There are transport issues, and right now it's restricted to massive burns. So what's the next thing? Okay, who here has Googled the skin gun? Oh, you gotta Google the skin gun. This is one of the best ad campaigns. This is a delivery device for stem cells. And this is the spray-on cells. And we are actually in the process of a study with the A-Firm group in the military. We're at one of the participating centers. This is the Armed Forces Institute of Regenerative Medicine, who is actually funding new and cutting-edge technology for wound coverage. And basically, we're putting this on second-degree burns, so they're still a dermis, and spraying the patient's own skin cells with their stem cells on it. And this is kind of the process where you harvest the skin, and we do, all this happens at the time of the first operation. So we harvest, and then I have to play chemist, which is not good. They send someone just special just to watch me do it, to make me do it right. Because I get impatient right about here, and we haven't even gotten halfway through. And then you have to put it in the little devices with the enzymes, and you finally can draw the enzymes up and you spray it. Not the final solution, but the stem cells technology. This is the first step. And I think that's where we need to go. You have to have a first step. And this is a good first step. And I'll know the answer to this in probably a couple years when this study gets done. There's no dermis, again, no sweat glands or pigment, and that's still in our infancy. Here are the issues that we have to address when it comes to skin and skin cells. Blood loss, optimizing coagulation, that's a whole nother prospective randomized trial we've got going. Looking at FFP and massive burn excision. We've actually got a randomized trial for that. And early skin coverage. Okay, you hanging in there? Can you hang in for a little longer? Okay, this is Arnold, dedicated to Arnold. Okay, these are all the anabolic hormones that have been used over time in an attempt to make burn patients stronger. Oxandrolone is probably the most studied of the substances. It's an analog of testosterone. It's actually used in AIDS myopathy. It's used in hepatic failure and COPD. So a lot of these people will actually get oxandrolone. It improves nitrogen balance and decreases weight loss. And that's where the idea came from the Galveston group about using oxandrolone. We've actually, in the Burn Multi-Center Trials group, completed a prospective randomized trial of oxandrolone versus no oxandrolone and found in these 81 adults with big burns that it decreased mortality and length of stay. So this was a step forward. So every burn over 20% now gets I call it the Arnold treatment. There's several other adult studies and studies in children that show improvement in constitutive proteins and reduction in hospital length of stay with oxandrolone. Okay, glycemia. Do you guys do intensive insulin therapy? Okay, what intensive insulin therapy is continuous infusion of insulin through a catheter to control blood glucose. And people wonder, well, why do we do this for really sick patients? These are all the bad things that happen when your glucose levels are high. So higher mortality, higher infection, less bone density, longer healing times. All these things are very detrimental to burn patients. Insulin is actually an anabolic hormone, and it can help with all those things. Now, hyperglycemia also causes insulin resistance and an increase in cortisol production. So it has this cascading effects. And details, you have to decide where you're going to sample your glucose levels from. Because if you choose a central line versus an arterial line, you can have a 20% difference in the glucose level. And this has to be done by protocol. One thing that nobody ever thinks about is the other medications you give at the time you're trying to control somebody's glucose. All of these agents increase the hypoglycemic effects of insulin. In other words, they make the blood sugar drop even further. So if you give someone an antidepressant, their blood sugar may drop, even on the same dose of insulin, even if you change nothing else. And this helps explain some of the erratic glucoses that you get, because there's a lot of these drugs we give in the ICU quite a bit that will actually drop your glucose levels. Others increase glucose levels, and probably my favorite that's not up here is vancomycin. Every time you give vancomycin, your insulin infusions almost predictably go up because vancomycin is in 5% glucose. But these are all agents that are going to affect glucose levels as well, and none of this is put in the algorithms. These drugs just don't show up. If you give this drug, you must do this to correct it. So we're always kind of chasing our tail with that. So what about insulin in burn patients? Decreases mortality, infection rates, improves muscle synthesis, and improves lean body mass. So all those things are good. The challenge is when you're going to the operating room. Now, anesthesiologists are getting better at this because one of the goals for cardiac patients is that they have to have tight glucose control. And so anesthesiologists are getting used to actually sampling blood glucose levels in the operating room, but it's still a dicey process. When people lose their feeding tubes, you have to remember to turn off the insulin because you're not getting the sugar. Dressing changes, a big stress. Oftentimes, patients will get very hypoglycemic as they're shivering and using energy during their dressing change. Anemia, most blood glucose monitors, actually blood glucose monitors, the AccuChecks, were not designed for the intensive care unit. They're actually designed with a 20% error is acceptable. It's for outpatient use only, but in the ICU, that's what we're using. So all these things can make it a little problematic. So these are all the questions we need to answer before glucose control can really come into being. So metabolic manipulations are a very promising avenue, and there are things that are coming along in the future. There's the most recently a DOD-approved study is a double-blind randomized trial of beta blockers in severely burned patients, and that'll be coming down the pike, probably the answer in 4 years. Refining glycemic control, and glutamine is another Dr. Hansbrough's favorite drug, is also being evaluated by the Canadians in a prospective randomized trial. So hopefully we'll have an answer there. So, question that I started with, right? You gotta finish what you start. How do we achieve an LD50 of 98% now? This is what the patient you have to have. You have to have one of those persnickety 5 to 16-year-olds who's not obese, who's not drinking or on drugs, has no other injury or smoke inhalation, they're taken rapidly from the scene, and they're burned next to your burn center. Maybe the hotel I was at is pretty close. We might make it there. Okay, treatment. Early and effective airway management, appropriate resuscitation, good excision and grafting like we described here, enteral nutrition, metabolic control, and aggressive mobilization. That's how you do it. Now, my final question, I'm going to leave these last 2 slides with you. Should this be our goal? Just because I can save you, does that mean it's the right thing to do? And that's a very hard question. And that's why the bulk of my research is outcomes research. And in Shriners, we have actually developed a long-term outcomes instrument. And I follow kids 5 to 10 years post-burn. And we measure things such as play, language, fine motor skills, gross motor skills, behavior, family interactions, pain, appearance, satisfaction, worry. And these are the results at the 5-year point for 0 to 5-year-olds. This is the hardiest group, pretty much. And what you can see is they never achieve normal pain scores. In pain, low is bad, okay? So they always have more pain, a little bit more pain. Their appearance never comes back totally. They're never satisfied because, your original equipment is the best. And, I don't blame them. I wouldn't be satisfied either. And parents worry. But you notice all the things that are good with these kids. They play. Their language skills, if anything, are above those of their counterparts at that same age group. Their fine and gross motor skills are good, right up with everybody else, and their behavior and family, if anything, is increased. So there is something long-term. There are a lot of good things. Where we have to work, we got to figure out how to make these people feel better about their appearance. We have to do better with their appearance. We have to do better with their pain long-term. At 5 years, they're still having issues. We have to see what we can do about satisfaction worry. Those are the goals that we need to achieve at this juncture. as well as concentrating on mortality. And you can see that children with hand burns have bigger problems. So that is more of an issue. And the elderly is the other population, who we haven't really budged survival a whole lot. We actually went back and took a 10-year period of patients and called every single patient over the age of 60 and asked them how they were doing. We gave them the SF-36 over the phone. We asked them what their functional status was, where they're living. And it was very humbling because the survivors, green, this is the survival curve of these patients. The green people in the green were sent home. So you can see at 3 years, 60% were alive. However, if you went to a skilled nursing facility, at 3 years, 30% were alive. Very humbling. And most of these people died within the first 48 months. So yes, we got them out of the hospital, but were we really successful? That person who went to the nursing home and died within a couple years probably never got out of the nursing home. So I think what we have to do is really hone down and say, okay, how can we improve, make them stronger, make them better, so that when they go home they can be functional and it's not just moving them somewhere else. And I think we need to up the bar. Mortality is no longer the bar. I think function is the bar. So although mortality will always be there and it'll be kind of that thing we strive for, we need to never lose sight of the fact that people need to survive and be functional. And that's why my research will never end, because I don't think we'll ever be perfect, but we'll always strive to do so. So much has been done to improve burn survivability, better ventilators, better resuscitation, excision, cultured skin. We still have a long way to go. And the question remains, should survival alone be our goal? Because remember, this is the pathway, this is the Cotswolds, by the way, one of my favorite hikes in England. And you just look over the horizon, and you want everybody to be able to walk this pathway and achieve the best they can after a burn injury. And we have a ways yet to go before we're there. Thank you.